I know I've got 5 minutes and I realise that we're a little bit behind schedule, so I'll just pick out 2 things. I'm sure everyone's had a chance to review the paper. The 2 areas I really wanted to pick up on was the NHS 111 procurement piece and also the referral to treatment. And Mike's covered that, I have to say, in his bit, but I think there's a couple of bits I'd just like to add. So the 111 procurement is actually phenomenally important for us. It's a very large piece of work. It's happening across the whole of Hampshire and a little bit of Surrey Heath, so Surrey Heath's part of that as well. And it's going to be, I think, it's not too small a thing to say, I think that the cornerstone for how we start to deliver health services in the future. It's a real visioning piece as well as offering us a day-to-day service right now. So everyone I'm sure is familiar with the 111 service, and everyone I think is familiar with some of the mixed stories that we might have heard both anecdotally and perhaps our own personal experiences around the use of the service. We've done an awful lot of public engagement around this, and also some really good engagement with local clinicians and people who may not have used the service but who might use the service in the future. And some of that feedback's been really positive. We've had some great feedback about how it can really work well when we get it right, and some feedback about how it's not quite as responsive as it needs to be. And we also know it can do a lot more as a service, so we know it could work as a single point of access for our whole health economy. We know it could be our single telephony point. We know it could act as a pressure valve really for our local health system, helping us to better manage some of the pressures that we have. The 111 links really strongly to the DOS, the Directory of Service, and what that is it's a directory of service that each provider puts together. It's the provider's responsibility, with the support of the commissioned services that they have, to say what they want patients to, what we want patients to do, and when we want them to go there. So if you phone up at a certain time of night, you might get directed to, say, a local MCP hub where a GP might be based, but after a certain time of night, that hub might be in a different place or for different services. And the idea is the patient shouldn't have to worry about where to go to. The service should help direct and signpost people appropriately. And it probably goes beyond healthcare really into how we also direct people across the social care system, making it much easier to navigate the way that we run service in the future. So we're going to tender for that service. We've just written a specification across the Hampshire and Surrey Heath borders to work out how, Heath CCG, to work out how we would like that to look, and that's based largely on patient feedback, largely on some visioning work that's happened across the STP, and largely on some of the feedback that we've got both from acute clinicians and also our primary care clinicians who've been also using that service. Also our nurses and local healthcare providers use the services, and also how we link in voluntary services into the overall piece, because obviously that's a fundamental building block for how we deliver services in the future, as Richard said in his STP presentation. I'm just going to turn to David now, because you've been our lead clinician for that. And I don't want to overemphasise, but it's such a big thing for us to be commissioning. It's going to make it's a 5-year contract, so it's a big piece of work for us. So I don't know if you want to add any perspective from you.
Well, it's, as you say, it's just the cornerstone of how if we glue all this stuff together. And I think one of the things that's really struck me is how people have been really keen to get involved. Normally you have to twist people's arms to get involved, and yet when we went out asking for clinical involvement, there were lots of people who've put their hands up, and some of the feedback has been incredibly useful. I think that has been at all different levels. So I think, and I have to say, expertly chaired. The groups have been expertly chaired by a member of our CCG as well.
Real quickie, sorry. The Hampshire County Council, Hampshire Direct. I know there was conversations about that. Is there any update on that then?
So actually what we've done is we've put that in innovation. So given the timescales of specification and some of the more detailed conversation that might need to happen around that, what we've done with discussion with Karen, is we put it as part of the innovation part of the specification. There's quite a large innovation section which allows us to develop services as we go along. So if we're not ready from day one, it definitely doesn't stop that happening. In fact, if anything, it strengthens our ability to have an ongoing provider discussion with Hampshire County Council, if that makes any sense. It's a much better piece. I mean, I'm actually really excited about this because I think it could make a massive difference to how healthcare services is delivered and make it much easier for patients to get in that service. So I'll shut up about that now. And the other bit I was just going to say was about RTT. Mike's just elaborated a little bit more on what Mike said. He talked about how we're working with the Trust. It's very much a partnership arrangement about how we work with developing the RTT target and making sure we can achieve it. The referrals come from primary care, and the problem is also in the acute trust. So actually across the system we need to think about how we manage our capacity much better. And that goes very much with the piece that Richard mentioned in his STP discussion